Welcome to Bear in Mind, the Brown Psychiatry podcast, clear, current content about mental health. I am the host, Dr. Tracy Guthrie, Psychiatry Residency Program Director and Co-Editor-in-Chief.
I'm Dr. Camilla Cosmo, Psychiatrist and Co-Editor-in-Chief.
And I am Dr. Micah Duggins-Worf, Psychiatry Chief Resident and Script Editor for today's episode.
First, a content warning.
In this episode, we will talk about sensitive topics, some of which you may find triggering. Our only purpose is to provide education and information. Our content is not to be considered medical advice.
Depression is the most common mental health problem in the United States and across the globe. 1 out of every 5 people on Earth will experience at least one episode of depression in their lifetime. Depression is a complex disease, and we have yet to fully understand why it occurs or how best to treat it.
What we do know is that there are many diverse factors that increase the risk of depression, from genetics and neurobiology to stressful or traumatic events, chronic health conditions, and structural social issues such as housing, education, access to healthcare, and finances.
In part because of the complex mental and physical manifestations of depression, it is predicted to be the largest cause of disability across the world within the next 7 years. It is also the single most significant risk factor for suicide. Luckily, depression is a treatable medical condition, and some of the most exciting research in psychiatry is concentrated on treatment methods to help people who are suffering from this illness.
Among the available treatment options, we have electroconvulsive therapy, or ECT for short. ECT is a safe technique that has been used for almost 100 years to help people with severe depression. During the treatment, the person is asleep, under anesthesia, and does not feel anything. Like with any other medical treatment, there are side effects. It is important to learn about the treatment and to talk to doctors to understand the risks and benefits.
ECT, or electroconvulsive therapy, is usually recommended when other treatments like medications and talking to a therapist have not helped enough, or when the person is very sick with a high risk for suicide and needs help right away. ECT can help relieve depression symptoms and help people get back to their everyday life.
Today we will talk about depression. So how is depression different from normal sadness or grief? What are some common symptoms of depression? How do we treat it? Does ECT really work? Is it safe? And perhaps most importantly, where can people turn for appropriate evaluation care if they are suffering from depression? To help us with these questions and more, we are joined by Dr. Alvaro Olivares, Clinical Associate Professor of Psychiatry and Human Behavior at Brown University and Chief of the Outpatient ECT Unit at Butler Hospital. Welcome, Dr. Olivares. It is our pleasure to have you here today.
The pleasure is all mine. It's an honor to be here with you.
Thank you.
As humans, we all experience sadness or feeling down from time to time. What are some common symptoms, Dr. Olivares, of depression, and how is it different from normal reactions to loss or disappointment?
I think that's a very important question. We all experience sadness, which is an emotion that we all have in our lifetime. It could be related to an event. It could be related to a person. It could be related to a loss. Depression is different. Depression is characterized by feelings of sadness for most of the day for at least 2 weeks. People tell me, doctor, I lost interest for everything. All the things, all the activities I used to enjoy, I have no joy on anything. In depression, major depression, people can have changes in their appetite. Mm-hmm. They can eat more, they can eat less, they can lose weight, they can gain weight. But also, some people slow down. Even their thinking slows down. Even the way they move slows down. Some people tell me that they feel hopeless. They experience feelings of worthlessness. There is this intense and persistent guilt. Some people feel that they have no energy, no motivation. And the worst part, and what you said, is that patient could experience suicidal thoughts. Thoughts that life is not worth living like that. And it is concerning because every 11 minutes, a patient dies from suicide in the U.S. So this amount is staggering, and it is a huge mental health issue.
Can you talk a little bit more, Dr. Olivares, about people that are struggling with suicide? How can we recognize those signs?
It is a challenge. It is a challenge for all of us because we need to assess the severity of their depression. And suicide is not just related to major depression. Mm-hmm. There are conditions that could lead to it. Mm-hmm. And we're living right now critical times in the world mm-hmm. with everything that is happening. One of the things that concerns me the most is that a combination of psychosocial factors such as hopelessness, social isolation, lack of emotional support from people, really, this pandemic has taken a significant emotional toll on patients, on all of us.
That's true.
And I think that we experience significant losses, and we really need to deal with that. Yes. When it comes to depression, I think that there has to be a really comprehensive approach to treat this condition. And we as society, we need to do more.
Makes sense. And although our understanding of depression is not completely full, what do we presently know about the risk factors that play a role in depression?
That's a very important question. We talk about genetics. We know that when we have family history of depression, meaning like a first-degree relative, a biological parent, or a sibling that suffers from depression, it really increases our chances of suffering depression. Mm-hmm. We also talk about what is called a chemical imbalance, meaning that there is some imbalance of neurotransmitters in the brain, such as serotonin, dopamine, norepinephrine, that could be associated with depression. Mm-hmm. But also there are life experiences that might contribute to depression, such as trauma, the loss of a significant other, the loss of related to a divorce, financial hardship, social isolation, also chronic conditions, such as chronic pain that's been associated to depression. People with, even with diabetes, they do have significant rates of depression. But one of the important things that we notice is that substance abuse. There are a lot of substances that do cause and trigger depression and might contribute to people feeling more depressed, especially alcohol.
I think a lot of our listeners, Dr. Olivares, may have heard about two common but very different approaches to treating depression, one of which is medication and one of which is talk therapy. Maybe you could tell us a little bit about why might one or both of these be recommended?
We always recommend a combination, meaning medications plus psychotherapy or talk therapy. But besides that, we recommend physical activity. Exercise is quite important. There are different types of medications to treat depression, and we select that according to the side effect profile, according to the patient's symptomatology. Talk therapy is very important. Psychotherapy, we call it, is very important because allow patients to express their feelings, to change these negative thoughts, to change maladaptive behaviors. But we also need to talk to patients about how to manage stress. Exercise is very, very important. Sleep, lack of sleep really might contribute, because sometimes when patients are depressed, they're not able to sleep or they sleep a lot. So healthy habits are very important. I tell all my patients that it is crucial to avoid social isolation, to reach out to friends, to reach out to family members, and to avoid drinking alcohol and using any illegal substances that could worsen their depression.
So how about ECT, electroconvulsive therapy? How does ECT work to treat depression?
ECT, electroconvulsive therapy, is a procedure that started in Europe. It started in 1938. There was this Hungarian physician that was double trained in psychiatry and neurology. And he noticed that when patients had seizures, they felt better afterwards. So he started really trying to induce seizures. Nowadays, we do have state-of-the-art machines that what they do is that they deliver an electrical current to the brain. So the patient is on the general anesthesia. We don't need any tubing involved. We do IV anesthetics with a muscle relaxant, but we measure the electrical activity in the brain. So ECT is the most effective treatment for depression that we have right now. All the patients that do come for ECT, they have by definition what is called treatment refractory major depressive disorder, meaning that they have held multiple medications, at least more than 3 medications. Unfortunately, when they come to us, They really feel that they're at the end of any hope. They feel, okay, if I don't get better, this is the end. And it's very sad because we do believe that ECT has been underused, not just in the US, but around the world. ECT is very effective for the treatment of what is called treatment-refractory depression, meaning up to 80% of patients do achieve complete remission of their symptoms of depression. Your question is very important, how it works. There are different theories. What we see, especially with all the brain imaging studies, is that there is an increase in blood flow to different areas of the brain. But there's also what is called neuroplasticity. We see that there is an increase of the synapses, meaning the connections of the brain cells or neurons in certain areas of the brain, such as the hippocampus and the amygdala. There is also an increase in the release of neurotransmitters, such as serotonin, dopamine, norepinephrine. And nowadays, we also see an increase in hormones, such as prolactin, cortisol. And there is new theories about the regulation of another system in the brain by the name of glutamate. But one of the important messages that I want to convey is that we want patients to reach out for help. We want to prevent suicide because ECT has been proven quite effective for patients with suicidal thoughts. It's one of the few treatments that we have in psychiatry that we do know, okay, it works. There are two other medications that have been proven helpful for suicidal ideation, such as clozapine, that is very reserved for patients that had chronic mental illness because it has significant side effects. And lithium is another medication that has been proven quite helpful to prevent suicide. But ECT is being used not just for major depressive disorder. It's being used for depression associated to other conditions such as bipolar disorder. It's being used for mania. It's being used for also what is called mixed episodes, when patients go from depression to mania or hypomania. It's being used for schizophrenia with very positive response. Nowadays, in the US, we don't use it as much. But if you review the literature in Asia, ECT is being used quite a lot for the treatment of schizophrenia. ECT is quite effective for catatonia. ECT is very effective. Nowadays, we have a lot of data for patients that suffer from dementia when they have really behavioral disturbances, and you tend to avoid some medications by the name of neuroleptics or atypical neuroleptics because they are associated with cardiac arrhythmias or with strokes. But ECT is a very effective treatment. Unfortunately, it's underused.
Yeah, so talking about that, so we know that a lot is said about ECT and that there is a lot of stigma surrounding it. Could you please explain the risks and benefits of ECT? And is ECT really safe?
Nowadays, it is. It is. We use state-of-the-art machines that deliver this electrical current to the brain. The patient is under general anesthesia, and also there is a muscle relaxant. So we're able to barely observe a seizure. We want the seizure to be longer than 20 seconds for the treatments to be effective. If the seizure exceeds 2 minutes, we ask the anesthesiologist to abort the seizure. So we give the patient a medication to abort the seizure. Now, ECT is quite effective. We see the response very, very quickly. When we start medications for depression, it could take 4 to 6 weeks for patients to respond. And when patients are very ill, when they're having active suicidal thoughts, when we fear for their lives, ECT is a very effective treatment. Most of the time, these treatments are on a voluntary basis, meaning the patients do give us the consent to do the treatment. There are times when we really feel as physicians that if we don't do the treatments, the patient's life is at risk. Especially the patient has catatonia, the patient is mute, the patient is not able to verbalize their feelings, but we do have family members. Sometimes we have to take patients to court because we do believe that their life is in jeopardy. I do remember one of my patients that had a positive response to ECT 10 years prior to that episode became quite depressed. She believed that her food was poisoned and really was refusing to eat. And the family was pleading to me to do the treatment. We couldn't convince her to do it. We have to take her to court. The judge granted us the permission to do the treatments, and we achieved remission of her symptoms, and we treated her successfully. One of the main side effects of the ECT is some memory issues, especially short-term memory deficits. Patients might tend to forget things that happened during the course of the treatment. For instance, what did I have for dinner the night before? Where did I leave my keys? Nowadays, people might say, okay, nowadays I have a cell phone, so I have GPS, so I can get to different places. But in the past, that was an issue. It is a temporary memory loss, meaning people do recover the full memory after 4 weeks after the last treatment. So the side effects, the main one is really the memory issues. With ECT, when patients do get the treatment, especially after the first treatment, there is a release of a substance called lactic acid. So patients, the muscle cells, they do release the lactic acid, so people feel like they exercise a lot. So we recommend very good hydration. People could take some ibuprofen or Tylenol, and that subsides in subsequent treatments. Because we have muscle relaxants in the past, when they didn't use that, yes, the people could have some fractures of their bones. We don't see that nowadays because we have the muscle relaxation that prevents that from happening. So it is a very safe treatment and a very effective one.
So who is not a good candidate for ECT?
That's a great question, because we do have, in terms of the selection process, we do have really what is called a medical clearance. Patients are seen by an internist. They do get a thorough physical examination, but also they do review blood work. They do review an EKG. If a patient had a myocardial infarction, meaning an infarction of their heart, we'll really like to wait at least 6 months to do a treatment, not to compromise the heart. Why? Because with ECT, when we give that electrical stimuli, what we see is that there is an increase in blood pressure as well as pulse. If the patient have an intracranial mass, we really don't want to do ECT. The reason being is because ECT raises intracranial pressure.
It's like a brain
mass.
Right.
So we really tend to avoid that. It's not an absolute contraindication, but it's very risky.
Makes sense.
Pregnancy is not a contraindication for ECT. ECT is actually quite effective for pregnancy. And we do it. Sometimes we do get OBGYN, meaning the gynecologist to be involved, the obstetrician to be involved, so we can do some fetal monitoring. But it's very effective treatment.
If someone were to have like a mental health condition during pregnancy, like they were to have depression or psychosis during pregnancy, ECT could be helpful, and you would just have some extra monitoring in place for the fetus if that was necessary, recommended by the OBGYN.
Yes, yes. One of the things that we notice and people are very concerned is, okay, if I'm going to get ECT and I have a seizure under ECT, do I have the propensity to have more seizures? Yeah. Nowadays, what we've seen is the opposite, that with every treatment we do, the brain raises the seizure threshold. So it's really more difficult for patients to have seizures.
So Dr. Cosmo alluded to this a little bit earlier, but there's a lot of stigma around ECT, and it's had a very bad reputation in the past. I think a number of our listeners will probably remember images of ECT from movies, from TV shows, as a very painful, dangerous, sort of prehistoric treatment. And I'm wondering what you would say to those people that have seen these images and are concerned about this as maybe a painful treatment, a dangerous treatment, something that should be in the past.
I think that you're right. There is a lot of stigma associated to it. One of the things that we tend to do is to educate our patients, not just with our own words, but also we show them videos about ECT. We really review medical literature with them. And we explain not just to patients, but to family members what we do, the rationale for doing that. And really with this state-of-the-art equipment that we do have, having an anesthesiologist in the room, having a physician that's been trained to do this procedure, having nursing staff that are very competent doing this, I think that we can assure people's safety. And it is unfortunate because it's underused, and a lot of our people and patients are suffering with the severity of their depression, and we want people to get help. We want to avoid people suffering day in, day out. They feel that they're at the end of their lives, but there is hope.
Mm-hmm. In your experience, Dr. Olivares, if you or a loved one were suffering from severe depression, would you recommend to have ECT?
Without a doubt. I've seen that it could save lives. I really witnessed the difference. I do recall the patient that was admitted to one of our psychiatric units, and she had major depressive disorder. And the family kept telling me, Dr. Olivares, she's telling us she's going to kill herself. She's going to kill herself. There is no hope. And we tried different medications at the maximum dosages that she could tolerate for more than 8 weeks. And there was no response. And we did ECT and really made a huge difference in this person's life, to the point that she was no longer suicidal, to the point that she went back to work. So you can see in how families are grateful to you because they feel that you have saved their loved one. So I have no doubts of the efficacy of the treatments.
And for patients that have treatment-resistant depression, in average, how many sessions are required for them to start to see the benefits?
That's a good question, because what we see in clinical practice is that it varies. It could be between 6 to 12 treatments. But there are cases when they do need more than 12 treatments. One of the observations, because there is not enough data on this, in patients that have bipolar disorder, when they're depressed, they tend to need a higher number of treatments to achieve remission from their depression. When patients have depression, but also they're in the autism spectrum disorder, I've noticed that their brains tends to be quite sensitive. So based on my experience, we regulate the level of energy according to their conditions. That's very important because we want to prevent any side effects. And on these particular patients, when you use high level of energies, they could have very long seizures. But that's based on clinical experience. And there is a lot of things that we could do and that we're trying to learn more from and do some research so we can really, all the practitioners could have more knowledge about what we see. So I really advise my patients and educate them about the importance of being completely sober and not to abuse any substances during the course of the treatments.
You know, Dr. Olivares, I love that you brought up the story of the family that was advocating so well for their family member who was depressed. And I'm wondering what you might share with our listeners in terms of, we've talked a lot about what depression is, the many treatments we can offer for it. What would you say to people in terms of when they should seek help for themselves, for a family member, where they can go for that help for some of these treatments that we've talked about today?
That's a very important question because there is, this is my line of work, but also it is important because there are some cultural issues, and it depends on the culture that you're dealing with. And there might be, I'm Latino, and there could be a lot of stigma associated to mental illness within my community. And I think that it's important for us as physicians to educate people about seeking treatment. And a lot of people do need help in these moments. We want them to reach out to us. We want them to reach out to their primary care physicians, to family, to friends. But to all these listeners, we want to stop you from suffering. There is help available. There are medications. There are treatments that do work for this condition. So when you find yourself that you're feeling sad, and this persists for more than 2 weeks, that you have no energy, no motivation, that you're not able to sleep or you're sleeping too much, when you don't have that capacity to concentrate, to finish your projects, and you're not able to, you start saying, okay, I really don't want to go back to work. I really don't want to do that. I mean, all of these are signs. We really need to prevent people from suffering, but we need to prevent people from killing themselves.
So Dr. Olivares, can you help us demystify this a little bit further? Can you walk us through the steps that you go through or the patient will go through when they are considering ECT, or it's been recommended to them? Where do you come in as the consultant or the practitioner who's doing it for your own patient? Walk us through the steps so that people can understand what happens.
That's a crucial question, because we do ECT on outpatient basis as well as for people that have been admitted to the hospital. The process is about the same. When a psychiatrist or a practitioner recommends ECT, we do a consultation, an evaluation, where we explain to patient the risk, the benefit, the side effects, the alternative to the procedure. But we also review the whole medical history, their psychiatric history, the risk factors, their family history, not just of mental illness, but medical histories to prevent any complications. After we have determined that the patient is a good candidate for the procedure and the patient would like to proceed with that, what we order is blood work and an EKG. So it's very simple. We get that done, and then the patient is seen by an internist, someone that have experience watching some sort of ECT, what it takes place during the procedure.
Mm-hmm.
After the patient's been medically cleared for ECT, then if it's an outpatient, the patient comes to our ECT suite. The patient is dropped off by a family member. The patient gets an IV. There is really very competent nursing staff. They do get the IV. They take the vital signs. We also do some questioning in terms of assessing their severity of their symptoms. So we do ask some questions. We document those questions. And then the patient, when they get to the ECT suite, they meet the anesthesiologist, the attending psychiatrist that is doing the procedure, and there is a nurse. So we talk to the patient. We always identify to make sure that is the right patient. So we review the bracelet to make sure that is the right patient. And we explain what we're doing. It doesn't take long. Usually the patient, after they answer those questions, the anesthesiologist might ask more questions, listens to their lungs, explain what they're going to do. There is no tubing involved. There's just an anesthetic that is adjusting according to the doses adjusted according to the patient's weight.
Mm-hmm.
Then, when the patient is completely asleep, receiving oxygen, then the patients get a medication to relax all their muscles. So before we do the procedure, the patient is completely asleep. There is no movement. So we do this electrical stimulation of the brain. We can do it on one side of the brain or both sides of the brain. There is a difference between unilateral and bilateral. Before we do that procedure, we discuss with the patients what their preference is. Sometimes during the course of the procedure, we might have to switch from one stimulation, one side of the brain, to both sides of the brain. The procedure doesn't last long. It takes about, as I said, the seizure duration could be between 20 seconds to 2 minutes. Then the patient wakes up in about probably 10 minutes. They're going to be in the recovery room. In the recovery room, they monitor the vital signs. They make sure that the patient is completely alert and awake before we bring him or her to their family members. We don't allow patients to drive after the procedure. For how long? It all depends. I have patients that tell me, hey, doctor, after the procedure, I went and played golf. And they function completely well. Some patients feel, I want to rest for the rest of the day. So driving is not an absolute contraindication. I ask family members to assess that before patients do drive. But it is a safe procedure. The anesthetics really, and the muscle relaxants have played a very significant difference when we compare to what happened in the past, when we didn't have these medications. But also is the state-of-the-art equipment that we manage that allow us to measure the amount, the level of the electricity that is delivered to the brain. Using more, using less according to patient needs. So it is a very, very safe treatment.
And how accessible is ECT, Dr. Olivares? Is it covered by insurance?
The answer is yes. When patients come to us, we do take care of the whole process, meaning not just the consultation, but we do have a staff that discuss these issues with their insurance companies, because these patients, they have felt a lot of medication. They feel very desperate. And when they refer to us, is because they have tried many medications that haven't worked. And so we really discuss these issues with the insurance companies. And yes, we do get approval for it. So it really prevents patients from having any copays for this procedure because of the severity of their condition.
So thinking about another aspect of accessibility of care, where in Rhode Island is this treatment done? Where can people go for this procedure?
Well, it's done at Rhode Island Hospital and also at Butler Hospital. They could be done on inpatient basis as well as outpatient basis. I have to clarify that when we do the treatments, after the patient finish what is called the index course, meaning, that we achieve remission of their symptoms, a lot of these patients do what is called maintenance ECT, meaning that they come here less often. We decrease the frequency of the treatments. ECT is usually done during the index course every other day, on Mondays, Wednesdays, and Fridays. During the maintenance phase of the treatments, we do it every week, every 2 weeks, then once a month. For how long? It depends on the patient. We really like to have good communication with their providers, because there are life events that could trigger a major depressive episode. And what we want is to intervene right away, rather to allow this depression to progress. So what we do is that we follow them closely. I usually tell them that the consultation is really that we're always available, but if they do need to come back after 6 months of the last treatment, we usually want to do another medical clearance to make sure that there are no new medical issues that could affect the course of the treatment.
So what you're describing in the whole process of ECT sounds to me very much like any other outpatient surgical or outpatient procedure. You get evaluated, you have some blood work and an EKG, you'll be cleared by an internist, and then you'll have the procedure, and then typically you're functional, potentially later that day or the next day, like happens for a colonoscopy or any other outpatient procedure. So just to sort of encapsulate that, it's the process around it is really not that different.
It's not that different. Even, we're more cautious because we get a medical clearance. When you go for an endoscopy or colonoscopy, you really don't get a medical clearance. Here, we really go through a physical exam. We review the labs, we review the EKG, and we make sure that the patient is in a good physical health to undergo the treatment.
Thank you very much, Dr. Olivares. It was our pleasure to have you here today. We appreciate your availability to share your expertise.
The pleasure is all mine. Thank you for having me here.
Thank you. Now, a take-home message to bear in mind.
While feeling sad is a normal part of life, depression is a mental health condition that is marked by lingering feelings of emptiness and hopelessness, and often affects sleep, appetite, and concentration. Treatment can be immensely helpful, although it may take time to find the right treatment for you or your loved one. For most people, some combination of medication and talk therapy will be effective, while severe cases may need more specialized treatments like ECT. Depression can happen in an isolated episode, but it usually comes back from time to time and needs regular follow-up care, just like any other health problem. In many cases, it can be managed by a primary care provider, but when the depressive symptoms are more complex or difficult to treat, you might need to see a mental health specialist like a psychiatrist or a psychiatric nurse practitioner. As we talked about today, there are several treatment options available for depression. You do not have to go through this by yourself. Talk to your primary care doctor and ask for help. There is always hope.
If you or someone you know is feeling depressed and having suicidal thoughts, please contact the Suicide and Crisis Lifeline by calling or texting 988 or accessing it on the web at 988lifeline.org. The Lifeline is a 24-hour toll-free phone line for people in suicidal crisis or emotionally overwhelmed. You can also go to your nearest emergency department and ask for help.
So thank you for listening to our podcast. For more information related content, please check out our Instagram, Facebook, and YouTube channel. Bear in mind the Brown Psychiatry podcast. Thank you.